This topic is angina. Angina is simply a chest pain that's in response to myocardial ischemia or vasospasm. And there's three major types. The first is chronic or stable, the second is unstable, and the third is variant or vasospastic. First, let's start with chronic or stable angina. Chronic angina occurs due to a fixed partial obstruction of the coronary arteries. Symptoms result when myocardial oxygen demand exceeds supply, and this is also called exertional angina. This is going to occur with exertion, such as with stress or during emotional upset. Clients will feel chest pain, nausea, and dyspnea, but the key with chronic stable angina is that it's going to be relieved with rest or nitroglycerin. It's also important to associate chronic angina with stable and predictable. Chronic angina is going to have a predictable pattern of onset, duration, severity, and relieving factors. Clients are typically going to know what's going to cause their angina as well as what's going to improve the angina. Chronic angina also usually only lasts up to 5 minutes. Because clients with chronic angina are stable, we're going to treat them as outpatient. Our goal is to decrease oxygen demand and/or increase oxygen supply as needed. Preventatively, we can administer beta blockers, calcium channel blockers, and long-acting nitrates. All of these are going to reduce the stress on the heart and vasodilate the coronary arteries so blood can pass through more easily. When clients experience acute pain, we can administer short-acting nitroglycerin. Like I said, nitroglycerin is a vasodilator, so we're going to open up the arteries, reduce the amount of pressure, and allow the blood to slide through past blockages. It's also important for clients with chronic angina to treat the underlying atherosclerosis. So we want to administer antiplatelet agents such as aspirin or clopidogrel to prevent the platelets from clotting together. And we want to administer statin therapy to help reduce cholesterol levels. If we can reduce cholesterol levels, we can reduce circulating lipids in the blood and help reduce plaque formation. If atherosclerotic plaques continue to grow and the vessels continue to become more occluded, stable angina can progress to unstable angina or even myocardial infarction or MI. As coronary plaques grow, they have an increased risk of rupturing. When these rupture fully or partially, we have unstable angina. This is also known as pre-infarction angina. Unlike stable or chronic angina, unstable angina occurs unpredictably. Clients may not experience the same symptoms with the same exertion. Sometimes more exertion could result in worse symptoms, and sometimes more exertion may not result in any symptoms. As unstable angina progresses, it's going to occur more frequently, it's going to last longer, and it's going to become more severe of pain. And these clients are going to experience pain at rest or with even minimal exertion oftentimes. Sometimes the pain is not relieved by nitroglycerin, and this can often last greater than 10 minutes. The goal for clients experiencing unstable angina is to increase perfusion. We're going to position the client in an upright position as well as provide supplemental oxygen. Doing these things is going to decrease the peripheral vascular resistance and thereby decrease the workload of the heart. If the client's heart isn't working as hard to pump the blood pressure is going to go down and the force pressing against plaques is going to decrease. It's also important to assess the vital signs as well as the heart and lung sounds of clients with unstable angina. Clients are often hypertensive and can even get to a hypertensive crisis because there is so much pressure being put against the plaques. If there's an increase in that pressure, or if the pressure stays at an increased level, that plaque is at risk for further rupture and can cause a myocardial infarction. We also need to obtain a 12-lead ECG for these clients. Sometimes we'll see ST segment changes, and these can indicate MI, whether the ST segment is depressed or elevated. We also need to obtain cardiac biomarkers such as troponin on these clients. Now, because troponin is made in response to infarction, it's not going to be an immediate result. Oftentimes, we need to redraw the labs a couple times with these clients over a period of hours to actually see an increase in the biomarkers. So clients having unstable angina may need to be hospitalized overnight or for a day as an observation status to make sure we rule out myocardial infarction. If clients are experiencing pain that requires medication, we can administer nitroglycerin as well as IV opioid analgesics such as morphine. Morphine is going to decrease the preload and again, decrease the work on the heart. It's also just going to reduce pain in general. Finally, if we have evidence of myocardial tissue damage, such as ECG changes or an increase in serum troponin, coronary angiography is warranted. We need to perform a cath so the healthcare provider can go in and visualize areas of the heart for blockages as well as tissue necrosis. The final type of angina is variant or vasospastic angina, and this is caused by a coronary vasospasm. It often occurs at rest or during sleep and could also be triggered by smoking. Now, this form of angina may or may not be related to a blockage of coronary arteries. Unfortunately, what's happening is the artery is spasming so much that it mimics an MI sometimes. ECGs may still show ST elevation like an MI, but it's not actually an MI, it's just a temporary occlusion. The pain generally resolves in a few minutes, but if clients are having frequent episodes, we need to monitor them and do things like collect a troponin to make sure a myocardial infarction has not occurred. Now, in vasospastic angina, we try to focus on preventing it more than treating acute. If we can prevent it in the first place, we're not going to have issues. So, clients often take prescribed, scheduled, long-acting nitrates and/or calcium channel blockers. If you think about calcium, it's going to increase muscle contractility. If we're blocking some of that calcium, we're going to reduce it and reduce spasms. If clients are having pain from an acute spasm, we can administer sublingual nitroglycerin, or we can actually encourage them to complete light exercise. That movement and stimulation of the heart is going to increase the blood flow and open the coronary arteries back up and reduce spasm.